Welcome everyone to the 2021 Hawaii Book and Music Festival. This is the Wellness Panel and a discussion on lessons for the future pandemics, lessons for the next pandemic and moving forward. What have we learned from this trying time and really this journey of discovery with COVID-19? We have a distinguished panel today, and I'd like to offer a brief introduction. There's Jonathan Dworkin, an infectious disease specialist on Hawaii Island. He has advised the mayors of Honolulu and Hawaii counties, and he's also the author of The Plague Doctors, How Hawaii Battled the Pandemic. Welcome, Jonathan. We have also Dr. Ellen Buenconsejo-Lum. She's at JABSOM, an associate dean at JABSOM, and the chief liaison between the university and various state entities on the matter of the pandemic. Also with us today is Dr. Thomas Lee, assistant professor of epidemiology at University of Hawaii, and he served for the Hawaii Emergency Management Agency as state's lead modeler and forecaster. He's also assisted the governor to formulate policy and is working as a medical planner for the U.S. Army Pacific. Finally, we have Nick Redding, the executive director of Hawaii Data Collaborative. His background is in social and organizational psychology from Columbia. Welcome, everyone. Thank you.
Thanks, Ira, and thank you, everybody, for having me. It's a real honor to be invited onto the virtual stage with such a distinguished group of Hawaii scientists and fellow physicians. You know, my own role in this starts as a clinical infectious disease doctor, and like a lot of other clinical docs, in February and March of 2020, I was sweating, seeing this thing coming at us and trying to wrap my head around how it was going to impact the state, how it was going to impact my clinical practice, and what the level of disruption was going to be. And very early on, there was a lot of confusion. You know, the topic of this panel is preparedness for the next pandemic. But I think before we can really assess that in an intelligent way, we have to first try to frame whether or not we did what we wanted to do during the current pandemic and accomplish what we needed to accomplish. So I have a few slides here that I'd like to share that come directly from the book. And the book is part memoir and then also part analysis of how Hawaii did. So I want to share some of these because I want to try to put into context how we did. And I want to you know, assess our performance and see whether or not the orthodoxy that Hawaii has done as well as it's done is actually holding up. So I'm going to try to share a screen here. One of the things I did with the book was I you know, looked at deaths and tried to compare Honolulu, which is the big metropolitan area in Hawaii, to other metropolitan areas in the United States. And this is data through March of 2021. Around spring, we start to see big discrepancies based on things like vaccination rate, particularly internationally. And what I was trying to get at was what was the effectiveness of Hawaii's public health policy? How did we do with non-pharmaceutical interventions, things like mask wearing, border control, various movement restrictions, all of the inconveniences we put up with as a state? And how did we do? And if you compare Honolulu to other metropolitan areas, it looks pretty good. Here you see New York, which had one of the highest mortality rates in the country. And then here's Honolulu all the way at the bottom. And you know, based purely on that, it appears that Hawaii was the success that we're often presented as in the national media. It's a little bit more complicated than that, though. Here's a slightly different graph. And what I did here was I separated Hawaii from the United States. The two dark black lines are Hawaii and the United States population in general, the United States death rate in general. And then I compared us internationally. And what you see is still pretty good compared to the United States. But if you look to the left, you see countries that did significantly better than Hawaii, and many of them are our neighbors in the Asia Pacific region, right? So Hawaii shakes out, you know, somewhere in the range of some of the better organized Scandinavian countries, but not nearly as good as Japan, Australia, South Korea, and nowhere in the same ballpark as New Zealand or Taiwan, which barely register on the graph. These are, island nations in the Pacific as well. Within Hawaii itself, though, you see a lot of discrepancy. So this is a graph that I think illustrates what might have actually been going on here. The dark black line is Maui, and this is cases, not deaths now. The light gray is Kauai. And what you see is prior to October 15th, if you look at the far left of the graph, both Maui and Kauai, and the reason why I choose these two islands is because they basically had very little transmission when we were under the mandatory 14-day quarantine. So these are islands that had very limited local transmission. And then on October 15th, we begin to open up. And what you see is both islands experience an increase in cases. And we're not talking about a huge case incidence here, but noticeable compared to the baseline, which was almost zero. And then on December 1st, Kauai withdraws, but Maui stays in. And what you see is the epidemic essentially extinguishes itself on Kauai, whereas you continue to have significant transmission on Maui. And this graph continues through spring of 2021. So, one thing I want to express is my admiration for the people of Kauai, who I think amongst everyone in the state really imitated and in some ways even exceeded the best countries in the world in terms of disease control. But it came at a cost to their island. We know from economic data, for example, that their unemployment rate was higher by the spring, and that they paid a significant cost for this success. And most of the rest of the state followed a more Maui-like pattern and accepted a certain amount of disease, transmission, and death in exchange for a limited economic opening. And all the attendant problems that came with that, including now what we're seeing with the resentment of the tourism industry and whatnot. So the question is, could we have had a curve that looked more like Kauai or New Zealand or Taiwan with less attendant economic destruction? And that's kind of the crux of what I wanted to get at. This was a picture I snapped when I flew into Hilo Airport during the winter surge, and it was in between flights. This was post-arrival testing on the Big Island that was established by Mayor Harry Kim during the winter surge of cases. And what I noticed was this picture was taken when there was nobody in line, but this line could go from 0 to a couple hundred people very quickly. And trans-Pacific travel resulted in a post-arrival rapid antigen test at the airport. And this was an attempt, I think, to do what Kauai was doing while allowing more travel to come into the state. And it was somewhat limited. It was at the airport. It wasn't at the ideal interval of time, which would have been, 3 to 4 days post-arrival. And so what this gets me to is what is real excellence in pandemic control. And I was thinking about this in advance of the panel discussion, and I, for myself, defined a few things that I would think of as excellence. Excellence is our case and mortality graph. The entire state's looking more like Taiwan and New Zealand, not the US mainland. That should be what we're trying to accomplish. Excellence would be kids in schools and local businesses open. Excellence would allow for travel at a modest volume, but ensure that it's safe, and it would do that efficiently. And excellence would also involve an investment in the long-term viability of Hawaii infrastructure, including biotechnology and software, which we never really stood up. And finally, I think this is as important as everything else. Excellence is social cohesion. It's an awareness of our history. It's an awareness of what happened to the Hawaiian people and why we have an obligation to make sure that something like that never happens here again. And excellence is people having reason to trust our institutions and cooperating with our attempts to control the disease.
The next talk is by Dr. Ellen Buenconsejo-Lum. She is a chief liaison between the university and a number of state organizations and serves as associate dean at JABSOM. Dr. Buenconsejo-Lum.
Hi, aloha everyone. Thank you so much for inviting me to this panel. And I've worn many hats, and so I think hopefully I can offer complementary perspectives that will help us really answer the question, how can we better prepare for the next pandemic? So I was a part of the HI-EMA ESF8, which is the Emergency Support Function 8, which is really the part in emergency management that deals with health, public health, and medical care. And as a liaison representative, I could comment on whatever I wanted and get asked to do whatever they needed me to do. And so it was definitely a busy spring, and I was certainly not alone. There were many colleagues from UH that participated quite actively. I played a role with Dr. Chris Qureshi in standing up a community care and outreach unit, who was really charged to try to identify the impacts, current and future impacts, both on organizations, and including organizations that serve, those that were already being hit the most hard. But then also the impact on individuals. And so our CCO unit had some key community partners from the Native Hawaiian, Pacific Islander, and Filipino communities. We also engaged key folks from the neighbor islands, from the different district health offices, and were able to conduct 2 surveys. The results of those are actually just published in a special issue of the Hawaii Journal of Health and Social Welfare. So that was one thing. And then a very quick apparent need was for the truly homebound elderly, because they were not able to get they're homebound. And so as the state was getting more access to testing and other things, they didn't have an easy way to do it. We were still experiencing PPE shortages, and we're dealing with vulnerable populations. And so how do you make sure that they have PPE and the appropriate training, and really all of the ultimate goal was to keep them out of the hospital. And so with that, we partnered with the hospice agencies and the home health agencies, partnered with Queens and HPH, who by that time had stood up their virtual COVID hotlines, which served as a resource to answer questions, but also manage people as an outpatient. And then, so we tried to help with that question. And then, of course, bringing in, helping to coordinate the resources of the university to support all of the different efforts. And then, October came around and vaccine came around. And so I helped, serve on several different vaccine implementation committees, including looking at from the provider side. So, we all know we've got, big health systems with networks, but there's also a lot of folks, especially on the neighbor islands, who may be in smaller practices, who may not have the capacity to provide vaccinations, yet the community trusts them, right? And so how do you really bridge that? And so that's the provider group, and then, medical advisory group, I'm the co-chair of that. So I guess my lessons learned, are that community engagement is important early, and I think we could have done better with that. And, that is definitely reflected in all of the early data, with showing a huge disparity with the Pacific Islander group, getting COVID. They represent 4% of the population, and at the peak, they were about 31% of the folks getting, positive testing. And we also see that reflected both in hospitalization data and in death data. And that was early on. And then this spring, after the advent of vaccinations, then unfortunately we saw that shift a little bit. And, with the Native Hawaiians, suffering disproportionately, and Filipinos. And so I think, getting the community engaged, meaningfully engaged and at the table, are important, because many of these solutions are going to come from the community. And, so certainly for the vaccine, there's a kupuna working group, because the needs of the kupuna are very different than the needs of ambulatory younger people, and the needs of businesses and for work sites, and how can they help keep that, so everyone's needs are different. And so it's important to set up infrastructures and communication structures so that everyone's voice can be heard and thought about very deliberately and very strategically. because we had to make some very tough decisions about, prioritization, right? Who's going to get the vaccine first when we were in a, short supply. And, we're certainly obviously guided by the CDC, but Hawaii's complexity meant that on the prioritization working group, we actually had a very, very difficult situation because we couldn't just use the CDC's criteria. We actually had to tailor it to Hawaii and look very closely at our demographics and delivery and important issues of equity. So infrastructure, community, and then partnerships is really, and making sure that we truly have the infrastructure to support and sustain partnerships. I think the biggest lesson has been the public-private partnerships that really had to emerge because initially in the early phases, it was very, very clear that the state couldn't do it alone, nor could the health systems, right? And so it really took everyone to do that. And I think that's been one of the strengths, certainly those early days, were rough. Everyone was really stressed out and stretched and dealing with workforce outages. But again, keeping that infrastructure, that communication infrastructure in place. And then, the last is the policy and, the time it took to set up different agreements, even between UH and the DOH, who are sister agencies, sometimes, you want to be compliant and all of that. And so I think we have a lot of good lessons learned that, I think could be put in place so that we can be more agile in the future.
Move on to our third speaker, Dr. Thomas Lee, Assistant Professor of Epidemiology at University of Hawaii. He served as the Hawaii Emergency Medical Association as state's lead modeler and forecaster, assisting the governor as well. Dr. Lee, what can you tell us?
I haven't been able to teach for a while. I've been on active duty, so chance for me to say this is me speaking as a private citizen and not as a military officer. I have to get that out of the way. I've had the pleasure of working directly with Dr. Buenconsejo-Lum within ESF8. Man, it feels forever ago, but April of last year, and then also with Dr. Renning and his team at Hawaii Data Collaborative, with the data piece. So a quick background. My role, Coconut Wireless. Everybody knows how small Hawaii is. I was teaching my global health class, telling my students, hey, in the news in January and February, hey, there's something called COVID, let's keep an eye out for it. And then I distinctly remember our last class right before spring break saying, hey, this could be our last class in person. And unfortunately, that couldn't have been truer. And so, I assisted a fellow colleague at JABSOM. She had some contact tracing questions. And then, it just ended up, I was asked, hey, do you want, we need an epidemiologist. There's a pressing question for the state. Do we need to stand up the convention center for as a field hospital? That was the originating question for the epidemiologist. And then so I willingly said, hey, let's take the plunge to support the community, and let me try to leverage my epi perspective, which I will say is different from my colleagues on the panel. I look more at population health. I don't have the expertise to look at the clinical side, though I do look at a lot of the findings there. So lessons learned, what I remember telling my students and doing in the early interviews is, what success did Korea, Taiwan, Japan have? And what set them apart initially was their prior experience with SARS and MERS. They experienced something similar. So to Dr. Buenconsejo-Lum's earlier point, they created policy which positioned themselves to react much quicker for COVID than a lot of other countries, United States, to name one of them, were able to do. So one example was they had standing MOUs with private companies to start cranking out testing kits to cut some of that bureaucracy. And the three pillars: testing, contact tracing, and isolation quarantine. Until we had vaccines, until we knew more about the disease, that will always be the tried and true infectious disease and epi method. So they were able to implement that, and then throw on the technology of they had versions of Aloha Safe, from day one or day two, and it took us quite a bit of time to get up to speed and utilize technology, understanding the uniqueness of Hawaii. So just lessons learned, and that's a good segue into to save travel. So my lead role when I was on orders to support Hawaii Emergency Management Agency was to provide a perspective of what is COVID going to look like in terms of a forecast, and really I took my role was twofold. One, to provide that service, but a step back was to just provide some epidemiologic understanding to the policymakers to help them understand disease transmissions and what they could and couldn't believe from some of the sites, CNN, et cetera. So it's important to note that in April, there was no Hawaii specific model that was accurate. The only one that was created was by University of Washington, HI-EMA, and their methodology had us peaking and being overrun in our healthcare system, I think 3 weeks into April. And what I worked with our team at ESFA was using a very basic infectious disease model where like there's no way, based on the epi information we knew, and there was very little at that time, that we would surge based on significantly the early action that the governor took to really shut things down. And we understand the economic consequences, but from a pure public health standpoint, that really saved us from some of the heartache that our sister states on the mainland suffered. So lessons learned, we reacted quickly relative to other states, however, it came with a significant cost. So, my hope from an epi perspective is from a testing and tracing strategy to continue to learn and fine tune Safe Travels Hawaii, Aloha Safe app, utilize technology that we have to leverage testing, contact tracing, to sync all those things together, and our isolation quarantine efforts, and to know that as technology continues to evolve for COVID, we're at a point where at-home test kits are becoming widely available, prescription and non-prescription over the counter, and eventually, hopefully, we'll have a spit test. It's a very cheap way, rapid test. But what I'm looking at from an epi perspective is, as more people get vaccinated, as people continue to get infected with the disease, but have mount a strong enough immune response, the number of daily cases will cease to be as important and really shift to, okay, how is our hospital system doing? And then Merck had some really great news. They cut short last week. They cut short their phase 3 trials of a pill form of an antiviral, which is going to be, I think, a game changer. You couple that with vaccinations, non-pharmaceutical interventions, and are trying to test it. So once again, I think from lessons learned, we did fairly well. We didn't do as well as Taiwan, but we were more forward-leaning than some of our other sister states. And I have a few more minutes, and I would be remiss as an epidemiologist not to talk about herd immunity and variants. And so, I think it's safe to say, 4 months ago when Delta and the Alpha variant were rearing its head, we didn't really take it as seriously. And so, the world and suffered for it, India first and foremost, and then we didn't really react quick enough. Right now, scanning from what little resources we have, I'm not seeing the Delta variant of the fall yet. But that's why it's important to continue to improve our existing systems. And I want to highlight, and I have to switch to my slide. I want to highlight that the federal government stood up earlier this year a National Center for Epidemic Forecasting and Outbreak Analytics, and the goal of that is to have continued and ongoing surveillance so that we're not surprised by future variants, but we're also not surprised by the next COVID, whatever virus that is, because we know speed with which we react is so important. So just want to talk about variants briefly, and then herd immunity. I think it's still too early to know. Is it 90%? Is it 80%? But what we do know is that we have highly effective methods of preventing and treating the disease through both pharmaceutical and non-pharmaceutical interventions. So I think chasing after some sort of percentage is less important than just continue to educate the public in terms of the evolving science of COVID and how we can continue to support our healthcare professionals and our healthcare system.
Nick Redding, the executive director of Hawaii Data Collaborative. His background is in social and organizational psychology with a PhD from Columbia. Dr. Redding.
All right, thank you very much. It's great to be with everybody here. Great to be talking about lessons learned from the pandemic, with the idea being we're moving on from the pandemic. We at the Hawaii Data Collaborative engage in partnerships to make meaning from data for solving Hawaii's pressing challenges. So my take in this panel is going to be a little different in that the perspective I'll be bringing comes from what we learned in supporting the data needs of those working to respond to the pandemic across sectors and topics. So 3 major lessons for the next pandemic: timely quality data matters, data connections matter, and data systems matter. So when we talk about the extent to which timely quality data matters, I want to really zoom out to say, you know, when have we ever seen so much interest in data and the extent to which data is translated to achieving the outcomes we all want? There wasn't anybody in the state that wasn't paying attention to data. It allowed all of us to understand what was happening and what needed to be done, because everybody had a stake in the outcomes. And the data needed to be good, and it needed to be timely, and there was no patience for deviance from that expectation. And so my hope from this is that the lesson learned about timely quality data matters can be a wedge that we keep going forward in terms of the important data, in terms of all the challenges we face, whether it's crisis challenges or chronic challenges. Timely quality data matters for achieving the outcomes we all want to see. Data connections matter. When we talk about data accessibility, it's not just about, can we get to the data? Is it posted somewhere on some website that we can bring down? But also, does the data have utility for our decision need? And then most importantly, does the data support the meaning making that we need to do? Shared problem solving necessitates shared meaning making at its core. Data helps us all ensure that we're talking about and measuring ourselves against the same thing. So meaning making should never sit in one place and with one organization. Our data should serve this purpose. So we did see, you know, a good amount of COVID data connections that came together very quickly and quite effectively in a short amount of time. The ESF groups, of course, have been mentioned, but also numerous private-public partnership groups around housing, food security, childcare, et cetera. Other secondary kinds of issues that came up as a result of the COVID mitigation measures. We saw other things like HI-PAM that Thomas is a part of, where a group of local concerned experts took the data that was available and extended it for predictive insight to start to bring more meaning to what we could expect. You know, what did we mean by flattening the curve? What can we expect in terms of the hospitals and other things that kind of lag behind the counts we were seeing? And then there was another effort, still is another effort, COVID POW, which took the data and did a lot of work on the communication side to translate that data for a wider audience. You know, and both of those are examples of trying to kind of lighten the load or take a lift in terms of the COVID data and communication needs from the state. And lastly, data systems matters. State data systems are challenged to support agency work within state data sharing and external data collaborations. And we all knew that. Anybody working on issues that relied upon interfaces with state or state data kind of knew that. But the pandemic really illustrated how critical it is to support modernization efforts. And those modernization efforts have been there. There's a strategic plan. They're still underway. But that, you know, this added to the urgency behind that. But it's also, it's not just the technical capabilities that need to be enhanced, but it's also the supportive capabilities that make for a robust data system or robust data systems. It's the skills and the bandwidth of those who manage the data and make use of the data and are gatekeepers of the data, and the supportive policies that allow them to do that effectively. Of the many things I could talk about that would make a difference on that, a conversation that's come up at least twice in previous legislative sessions is around the chief data officer. This has been advanced previously. I think it might be coming up in the next session. And essentially, a chief data officer is the counterpart to the chief information officer. They're helping us think as a society, as a state, strategically about the role that data plays, how we can enhance our data systems, and how we can start to support agency goals around the data work that needs to happen internally. Imagine if we had something like this in place in a time of crisis like COVID, the role that a chief data officer could play in responding very quickly to the needs of the agencies, the connections between the agencies, and the data sharing needs out to everybody else who really would have benefited from the data that was available. This is something that can be done and brought to life in parallel with modernization effort, which would then also make technical modernization more effective. So, in summary, good quality data matters. And when we don't have it, we're not able to effectively respond to pressing challenges. Data has broader utility than where it sits, and the extent to which we are all able to connect through data enables more effective action. And our data systems and capabilities are far from adequate at this point, given what we actually need. And the sooner we address the data systems limitations, the better prepared we'll be to confront the challenges we face going forward, including the next pandemic. If any of this high-level kind of overview of our lessons learned from data challenges in the state is interesting to those on the talk today, I encourage you to go to our website at hawaiidata.org. We wrote a report about this where we actually went out virtually and spoke to many folks across sectors and domains of interest to get their perspective on what are the challenges and what are the opportunities with our data and data systems.